Hello, and welcome to Informed in 30, a new series from the National Brain Tumor Society designed to give you, our patients and caregivers, everything you need to know about cutting-edge advancements in brain tumor research and treatment. Our topic today is innovations in brain tumor imaging. My name is Rachael Kittleson, and I'm the Director of Community Relations here at the National Brain Tumor Society, and I oversee our Connections program, which provides support and assistance to individual patients while advancing connection and care for our entire brain tumor community. I am also a member of the community as a former caregiver to my daughter, who passed away from glioblastoma in 2017. Joining us today is Dr. Kirk Tanner, National Brain Tumor Society's Chief Scientific Officer, and Dr. Ben Ellingson, Professor of Radiology and Psychiatry and Director at the UCLA Brain Tumor Imaging Laboratory. Thank you both for joining us today.
No, thank you, Rachael. I'm really pleased to be a part of this Informed in 30 series, bringing important, cutting-edge, and timely information to our brain tumor community. In today's installment, we are very fortunate to be joined by one of the true leaders in advanced imaging of brain tumors, Dr. Ben Ellingson.
Thank you. It's a pleasure to be here.
Great. So without further ado, let's get started. Dr. Ellingson, can you give us an overview of brain tumor imaging and really what that means to patients? What are the different kinds of imaging and how will that inform treatment?
Thank you. Thanks for the invitation. And I'm happy to be here and to speak on brain tumor imaging in this series. So imaging is really a cornerstone of both patient care and drug development in neuro-oncology. MRI and PET imaging are routinely used for clinical monitoring and response assessment. Historically, though, other techniques were used. So I want to step you guys through a little bit of a brief history on the use of different imaging technologies in neuro-oncology. Prior to 1918, no imaging was really available. Location for surgery and for treatment was based solely on symptoms and the neurologist's kind of perspective on where he thought the brain tumor was localized. From 1918 to the 1930s, pneumoencephalography was used. Now, on X-ray, brain soft tissue is not easily seen. So in 1918, Walter Dandy injected air into the ventricular system, or the ventricles, and this allowed us to see the surface of the brain. And it was a great advance in neurosurgery for the time, but it ended up being very dangerous for the patients. In the 1930s, through the present day, cerebral angiography, where iodine was injected into the vascular system, into the blood vessels, in order to see where the blood vessels were under X-ray, was used pretty routinely. And it's still used for certain types of brain tumors and certain types of surgeries today. From the 1970s to the present, computed tomography, CT, or computed axial tomography, CAT scans were used. This technique utilizes a series of X-rays that are rotated around the patient and then reconstructed to make two-dimensional images. And then it's repeated for multiple slices, kind of like a loaf of bread, and then combined together so you can see all of the images of the patient's head. From 1973 to present, positron emission tomography, or PET scanning, was used. And this technique uses biochemicals, chemicals that are very similar to chemicals that are found naturally within your body, that have a small bit of slightly radioactive antimatter to image tumor metabolism. And we'll go over this in a little bit more detail later about how this actually works. But the idea is that it emits a small bit of radiation, and we have a gamma ray detector that is placed around the patient that picks up these photons and this energy as it's released, and then we can reconstruct the image and identify where that biochemical is localized within the brain. You can see here a comparison between MRI and F-DOPA PET, which is a type of PET tracer that labels an amino acid, and you can see the resolution or the quality of the images is quite a bit different between MRI and PET imaging. From 1977 to the present, magnetic resonance imaging, or MRI, has been used. It was first developed in 1973 by Paul Lauterberg and Sir Peter Mansfield, who later won the Nobel Prize for the first MRI images. And in 1977, the first human MRI scan was achieved. And you can see the quality of that scan here in 1977. And you can see the first MRI scanner here, picture. And in 2021, currently 1.5 Tesla and 3 Tesla MRI scanners are used routinely for patient care. And you can kind of see here where we started with the very large primitive system, the size of an entire room, all the way to the high quality, high-end machines that you're used to seeing today. So how does MRI work? Well, these protons that are on water molecules, or H2O, the H is on H2O, actually have properties inside them that they act like small bar magnets that wobble when it's put into a magnetic field as they try to align with that magnetic field. And so what we use is non-ionic, so low intensity radio frequency energy at this wobble frequency. So we tune it to be at a specific frequency, and this causes those protons to temporarily absorb some energy. And this radio frequency energy is actually at the same frequency, roughly, of your car radio. So we use similar antennas to kind of see this sort of information. So you can see here that wobble, by applying some low intensity radio frequency energy, we're able to manipulate these protons to absorb some energy. And different types of tissues, depending on their environment, release this energy at different times. And the rate at which this energy is released or dissipated is known as T1 or T2. So when you see T1 weighted, T2 weighted images, when you discuss it with your doctor, this has to do with the different characteristics of the underlying tissue. So why use MRI? Well, first of all, there's no radiation. We only use magnetic fields and radio waves at low intensity, so it's relatively safe. There's better soft tissue contrast. You can see a CT scan or CAT scan here in the same patient and the MRI scan here, and you can see a lot more detail within the brain. Another advantage of MRI is that there's multiple ways to acquire images. We can acquire soft tissue contrast looking at anatomy. We can acquire physiology, so look at blood flow and different processes. And we can also use it to look at metabolism within the brain, all within the same system. So one question that often comes up is MRI safe, and what are the risks? Well, as I mentioned before, there's no ionizing radiation, so it's not like CT scan or other types of imaging technology that use radiation. We're only using magnetic fields and radio waves, which have been shown to be relatively safe. There is some risk of tissue heating, though, and what's known as the specific absorption rate, or SAR. But all of the systems that we use are FDA cleared and kind of monitor this sort of thing. So it minimizes the risks associated with the patient. Now, another risk is claustrophobia, which I'm sure we're all aware of. So, in order to mitigate that, there's some strategies to, play music or have the patient have their eyes closed and things like that. Or there's medication that we can use to kind of ease some of those symptoms. There's also a risk of what's known as peripheral nerve stimulation. So with some types of MRI scans, some sequences that are acquired very quickly, for example, you may feel nerve tingling or kind of twitches in your back at times. But again, that's monitored by the system and mitigated. We're all aware that the MRI system is very loud. So often you're given earplugs or headphones in order to cancel out that noise. Another perceived risk is the use of gadolinium-based contrast agents. So older, what are known as linear agents, has to do with how the chemicals were kind of constructed. Evidence suggests these appear to accumulate in certain parts of the brain over a period of time in repeated injections or repeated examinations. Now, since this was noted, there are newer kind of what are called cyclical gadolinium-based contrast agents that don't seem to have this effect that most of the hospital systems have now transferred over to. So another important fact is that there's no evidence that this actually changes your brain's function or impacts your quality of life at all. It just seems to be anecdotally accumulated in certain areas of the brain. So in many cases, clinicians have to really balance these benefits over the risks to the patient. The benefits that we get from understanding what's going on with the tumor and understanding if it's growing or not far outweigh the risks associated with this repeated exposure in many cases. So let's talk briefly about some of the common MRI sequences that a patient may experience. And this comes from a publication that we put together with thought leaders in the field, with the FDA, with the NCI, facilitated by NBTS, where we came up with a consensus recommendation for a series of sequences that are to be known as the standardized brain tumor imaging protocol for use in clinical trials, but also clinical care. There's a brief webinar that you can see on YouTube here where you can check this out, and it has a lot more detail. But you may be familiar with some of these types of sequences. So routine clinical care is really looking at anatomy of the brain and trying to understand if the tumor is growing or not. So we use a couple of sequences, the first being a T2 weighted MRI, and we'll go through these one by one and kind of what they measure and what they tell us. There's also T2 weighted FLAIR MRI that you may have experienced, as well as pre and post contrast T1 weighted MRI. You can see the pre and post contrast images over here. And lastly, something that's also integrated into this standardized imaging protocol is something known as diffusion weighted imaging, or DWI, that tells us a little bit about cell density and the tumor's density. So first, T2 weighted MRI. T2 weighted MRI is a technique that tells us something about the rotational mobility or the movement of water within an environment. And so what happens is with this sequence, water that seems to be within cells or bound to the surface of different structures is less mobile and tends to be dark. So you see in areas of the white matter or areas of the bulk brain here, it's relatively dark. In areas where we have free mobile water that's just kind of flowing around, like in the cerebrospinal fluid or the ventricles here, those tend to be bright. So it's really related to the amount of water content within the images. So mobile water has what's known as a long T2 of the signal, and so it shows up bright. So anytime you're looking at a T2 weighted MRI, the brightness tells you how much water content is within that particular area of the brain. There's been some studies that have actually confirmed this using a variety of model systems and kind of confirm that by weight, that T2 measurement or the brightness on those T2 weighted images correlates very well with the amount of water content. Now, we use this sequence, again, to see the amount of water content, but in order to look at two kind of characteristics of the tumor, the first being vasogenic edema, or sort of water accumulating within the extracellular space. So you can kind of see on this image here, this is all water kind of accumulating outside of the cells and outside of, the brain cells. And then we see areas of tumor where the cytoarchitecture or the brain tissue is actually being destroyed and replaced by tumor. So both of those end up having a little bit extra water content within that environment and show up brighter and indicate to us that something isn't right. Another sort of twist on this T2 weighted technique is called FLAIR imaging. And FLAIR imaging stands for fluid attenuated inversion recovery. And what this technique does is it suppresses or makes dark anywhere where we have CSF or pure fluid. And that allows us to kind of see areas where maybe fluid is next to non-enhancing tumor or next to brain tissue of interest. And we can better sort of delineate where the extent of the tumor is. Now, it does have some limitations. As you can see in the same patient here, it's really hard to tell the difference between areas of edema and areas of non-enhancing tumor because they both kind of have that bright signal and they both kind of look muted compared to the rest of the background. So it allows us to have very sensitive technique to kind of see where the abnormalities might be occurring, but it's not very specific to discriminating between these two different types of tissues that may, co-localize within areas of tumor. Another sequence that's commonly used, and probably the most commonly used in higher grade brain tumors, is pre and post contrast T1 weighted MRI. So in normal vasculature, when we inject gadolinium-based contrast agents, it stays within the blood vessels, within the vasculature. So after we, administer this contrast agent and we do our scan, we can mostly see, we mostly don't see contrast enhancement within the brain. Now, brain tumors, when they start to generate their own vasculature, their own blood vessels, these blood vessels tend to be leaky. and tends to leak out those gadolinium molecules into the extracellular space, into this sort of space between the different cells. And so you can see in areas of highly aggressive tumor, you can see on the post-contrast T1 weighted images, you can see where that gadolinium has leaked out into the extravascular space, and it highlights the area of the most aggressive components of the tumor. And this has been confirmed in multiple studies where they've actually went in and taken out different pieces of tissue, where they've confirmed that this contrast enhancing component on either MRI or CT back in the day really has the highest density of tumor cells and the most aggressive features. So that's why, we deliver contrast. That's why we use it. And that's why it's important to do so. Another sequence that's often acquired is called diffusion MRI. It's now routinely collected as part of standard neuroimaging protocols from anywhere from brain tumors to stroke. And it's really highly sensitive to ischemia and infarct and any complications that you might have, but it's also highly correlated with tumor cell density. The idea is very simple, that we're looking to quantify, again, water mobility within that extravascular space. It's very similar to this process of diffusion that you're familiar with using food coloring. So if we put a couple of drops of food coloring in water, as over time, that food coloring diffuses and eventually mixes up evenly throughout that vial. Now, with diffusion MRI, we're essentially labeling water molecules at two different time points and looking at how far they diffuse and their characteristics of diffusion. So the idea is that water will become less mobile when you have a high cell density and when cells are really packed in really tight. And so if we look at what's called the apparent diffusion coefficient, or the measured quantity on these images, it looks much like a T2 weighted image where we're looking at water content and water mobility. You can see in areas of edema where we have fluid, you're going to see a high ADC. It's going to be bright on those images. In areas of necrosis or cerebrospinal fluid where you have a lot of fluid, again, it's going to be bright. It's going to be high. And then in areas where you have high cell density or viable tumor that's sort of growing, you're going to see pockets of low ADC or dark on these diffusion weighted images. So that gives us an idea of kind of what's going on. That combined with the other anatomic images can really help us kind of differentiate, is this tumor growing or is it responding to therapy? Next, I want to talk briefly about what PET scans are, why they might be useful. So PET scans, as I mentioned before, use biochemicals labeled with a small bit of slightly radioactive antimatter. So this really is, space age technology, looking at dark matter, essentially, to image tumor metabolism. So an example of that you're probably familiar with is glucose or sugar. So we can label that glucose molecule, which you see here, chemically, with a radio-labeled fluorine that releases positrons, or this antimatter, and we essentially replace one component of this naturally occurring chemical with this slightly radioactive isotope. And we inject a small bit of that, small concentration of that, and it is not metabolized in the same way that glucose is, so it's trapped within cells that are using this sugar as fuel. So as it becomes trapped within the body or within those cells, it then we know kind of what cells are kind of using that sort of information. We also use a variety of other types of PET, what we call tracers or molecules, to kind of understand different aspects of metabolism. One commonly used technique is radio labeling amino acids. These amino acids are the basic building blocks of your body. And tumor cells, if they're growing and replicating themselves, need a lot of amino acids in order to build more cells. And so you can see three commonly used amino acids that are radio labeled: methionine, tyrosine, and L-DOPA. And you can see the radio-labeled version of that, where here we've radio-labeled a carbon. Looks very similar to the naturally occurring substance. Here we replace a fluorine, And then here with F-DOPA PET, we put a fluorine on this molecule as well. So it's very similar to the natural occurring substance, just a slight modification with a slightly radioactive tracer or molecule that tells us kind of where it's accumulating. Now, the cool thing is that this antimatter that's released by this slightly radioactive substance comes in contact with actual matter, like electrons and things within your body, and annihilates. It dissolves essentially and releases pure energy in the form of high energy photons or light. These two high energy photons are emitted after they annihilate. They are released at exactly 180 degrees apart. So we can create a line, where we're basically looking for where these photons are happening or are released from the body. And depending on when they occur, we can actually triangulate and determine where the source of this biochemical uptake is by looking over a period of time as these photons are released. We can then use computers essentially to recreate some of these images. So, why are they useful? So they're really useful for identifying tumor versus non-tumor in many cases. They're also useful for understanding, visualizing, and quantifying different aspects of tumor metabolism. Now, one of the challenges is for clinicians is to try to get insurance to reimburse some of these techniques. So they often reimburse your MRI exams, but repeated PET exams aren't always covered by insurance. So that's an important consideration. Here we see a variety of different types of PET scans. Here is FDG PET looking at glucose consumption. And you'll see that it's not very useful for kind of routine diagnostic care simply because the normal brain, this is the cortex or the gray matter, uses a lot of glucose, but so does the tumor. Here we have FLT PET, which looks at proliferation or the amount of times that tumor cells are kind of making new tumor cells. And we're able to see where in the tumor, cell replication is happening the most. Here's F-DOPA PET, or that amino acid transporter, and we're able to see where, amino acids are being accumulated. But there's also some more exotic things that are being used by a variety of institutions. Here's an example of a radio-labeled bevacizumab or Avastin molecule, so we can see where that drug may have an effect. So we're able to radio label different types of drugs. We're also able to look at hypoxia where the tumor might be oxygen starved. That can tell us information about how well it's going to respond to treatment. And there's a variety of new immunotherapy studies that are relying on different types of immunopet, where we're labeling different aspects of either T cell or immune cell metabolism or different aspects of the immune environment. So these are exciting things that are on the horizon. So what are some of the newer or cutting edge imaging techniques that you might be exposed to or you might be interested in? Well, one is perfusion MRI. You may have heard about this. This is a technique that measures blood vessel volume, or the amount of blood vessels, as well as blood flow. So this is also called CBV, cerebral blood volume, or CBF maps, the cerebral blood flow. And it can tell us where in the tumor where you're getting the development of new blood vessels. And this, again, indicates where you might have the most aggressive components of the tumor and whether or not it might be treatment effects versus growing tumor. So as tumors start to grow, they release these what are known as growth factors that either co-opt existing vessels that already exist in your brain to make new blood vessels, that then the tumor uses those blood vessels to deliver nutrients to grow even faster. Here you see a comparison in a patient with a glioblastoma showing a post-contrast T1 weighted image where, again, this contrast agent leaks out of abnormal vessels. But you see this whole area seems kind of abnormal, and it's hard to tell, well, what's tumor and what's dead tissue or just treatment effects. If we run this perfusion scan, and this is a map of cerebral blood volume, you can see these areas here have a lot of blood volume, a lot of blood flow happening, whereas this area here, it actually has no blood flow or blood volume. And so this area here that's leaking contrast is simply just dead tissue and indicates sort of treatment effect, whereas this other area seems to have a high level of new blood vessels. Another technique that you may have encountered for pre-surgical planning, for example, or if you're involved in research studies that are understanding, neurocognitive function or general health of your brain, is called functional MRI or fMRI. There are two different types of fMRI that you may be exposed to. The first is probably the most common for pre-surgical planning, and this is what's called task-based fMRI. And in this, you're told to do a specific task, like tap your finger, speak, read a book, look at something. And so those are the types of tasks. And this tells the end result tells us which areas of the brain are involved in certain functions. So in this case, for example, this is an fMRI task-based motor function task, where you can actually see the tumor has displaced the area of the motor cortex that's involved in this specific task. So the tumor is safe to sort of take out and not get motor deficits, for example. But surgeons, if for example, motor function is localized or occurring within the tumor, they may avoid taking out a piece of tumor in order to maintain that functional integrity of the patient. There's another type of fMRI that's used often now, mostly for research, but sometimes in the clinic, called resting state. So the difference here really has to do with task-based. You're asked to do an actual functional task where you're tapping your hand or doing an activity, whereas resting state really has to do with having you lay there with your eyes closed in a resting state. And it tells us the general health and integrity of networks within the brain that are normally maintained. Some of these are very similar to the types of things that we'd be looking at in task-based fMRI, but it gives us kind of a more general sense of the integrity of these networks like language and motor. So here you see an image here of a 3-year-old, and then their tumor here, and you see these are areas that are involved in motor function known as a language network, and areas that are involved in this motor network. And so you can see, which areas of the tumor might be impacting this whole network as opposed to a very particular function. Another technique that you may encounter for pre-surgical planning or for research purposes is called diffusion tensor imaging. This is very similar to the diffusion MRI technique I mentioned before, where we're looking at cell density, but instead in this technique, we're measuring cell density in a variety of different directions, and then we reconstruct mathematically where there might be, white matter or neuron fibers or axons in what's known as tractography. So here you see a nice image here. This is a tumor here, and all of these tell the surgeon or the clinician which areas of normal sort of axon or neural pathways are intact, which ones are going through the tumor, which ones might be affected. Here's another example of the cortical spinal tracts, or tracts that go from the spinal cord up into the cortex and are mostly involved in motor and sensory function. And you can see, they're slightly adjacent here to this area of tumor, which might be affected. So that tells the surgeons, where to cut, where not to cut to avoid some of these functions. This can be combined with different techniques like brain stimulation directly in order to get a sense of function and which axon tracts or which pathways might be affected by that function. So not just the area in the brain that may be having that function, but what areas are connected that if we sever those paths during surgery, they might have functional deficit. So again, this is very commonly used for pre-surgical planning to avoid damage to the brain. You may have heard also of MR spectroscopy or MRS. This is an MRI technique that's used to quantify and visualize specific biochemicals and metabolites using MRI. I mentioned before that MRI is looking at the protons or the hydrogens typically within water, because water is really the most abundant molecule that has hydrogen in it within the body. However, a lot of other molecules have hydrogens attached to them. So we can use spectroscopy in order to understand the concentration of these different metabolites like choline, like creatine, like these other metabolites, and where they're localized within the brain. That tells us a little bit about the metabolism and what types of nutrients and things that the brain tumors are generating or using as fuel. There's also some new techniques looking at the tumor microenvironment, specifically looking at acidity and oxygen utilization. So this pH and oxygen weighted imaging uses MRI techniques and non-invasively, so no contrast or anything, in order to estimate where tumors might be acidic and where they might be, have low oxygen. And this is important to understand treatment resistance and how aggressive these different tumors are. Here you see some examples of hypoxia-weighted or oxygen-weighted and tumor acidity, and you can kind of see where these areas of acidity and oxygen utilization are kind of co-localized, and that tells us something about the behavior of the tumor and potentially resistance to various therapies. Also, there's a new set of imaging techniques that are looking at immunotherapies called immunopet. And this uses PET imaging in order to understand response to immunotherapies or immune response in general. And the idea in some cases is to look at metabolism. In some cases, it's to look at different antibodies that might bind to immune cells or tell us something about the immune microenvironment. So these are sort of cutting edge things that you're probably going to see in the near future as immunotherapies are used more and more often. So what are some of the main limitations of imaging brain tumors nowadays? Well, the first is lack of standardization. So just because all MRI systems are 1.5 Tesla or 3 Tesla doesn't mean that every MRI exam is the same. This can make comparisons in the same patient over time particularly difficult if they're not scanned on the same scanner with the similar parameters. You can see here a patient with a glioblastoma where they were imaged using a 2-dimensional imaging technique and then a 3-dimensional technique, slightly different acquisition parameters, slightly different tilt. And you can see the tumor looks a little bit different. And so you can imagine if a patient's being scanned in one scanner and then another scanner and then another scanner, it can be difficult to kind of interpret what's going on over time in that patient. So really, we recommend trying to get scans on the same scanner with the same set of sequences over and over again. Another solution to this is, again, asking for the standardized brain tumor protocol that was developed in 2015. So in this publication, we describe the series of basic MRI techniques that should be done and some recommended parameters so that people can we can compare within the same patient over time, as well as look at a variety of patients with the same sort of acquisition to make some comparisons and understand drug effects a little bit better. Another limitation that we currently have is lack of image alignment. So if a patient's head is slightly tilted each time they get an MRI scan, it can be really hard for the radiologist or clinician to kind of compare these images over time. Here's an example from a patient here where simply we just rotated the patient's head and to look at the effects of just head rotation. Here you see the original tumor here. Here you see when the patient rotates their head slightly in one direction, you can see it looks totally different. And here you see the same relative image slice rotated in a slightly different direction. Each time, again, this is the same exam. Each time that we do this with a slightly different head tilt, the brain tumor and the size of the brain tumor looks dramatically different. So one solution to that we found is what's called image registration. We can align these brains to each other over time and then reslice them digitally in order to kind of see what's going on. We're also advocating the use of what are called digital flip books. So the clinicians can kind of scroll through and flip through these images over time and kind of, identify areas that are growing and shrinking over time. I'll give you a quick example of this. So these are images that we've, again, aligned, resampled, and then we look at kind of over time to see if the tumor is growing and shrinking. So in these first set of slides, you're going to see the tumor growing over time in these same images. And then you can see, an effective treatment response where the tumor is actually shrinking over time. Another limitation of brain tumor imaging, which you're probably aware of, is trying to differentiate between treatment effects and tumor recurrence, or pseudoprogression and tumor recurrence. So I mentioned before that growing tumors leads to more vascularity or more blood vessels. And these blood vessels are abnormal typically, and they leak contrast from the extravascular or into the extravascular space or the space around the tumors. This can look like enlarging, enhancing tumor. And this is why we use contrast to kind of monitor patients, because it's a really good surrogate or indicator of where the most aggressive parts of the tumor are. However, chemotherapies, radiation, different types of immunotherapies can also cause damage to the blood vessels themselves. So and existing blood vessels, this causes them to become more leaky as they're sort of damaged and can no longer have their integrity. This can also increase the amount of contrast enhancement that you see on these images, what is known as treatment effect or pseudoprogression, because it looks like progression, but it's really not. Now, one thing to keep in mind is that almost always after treatment, there's a mixture of both tumor cells and residual tumor and the effects of treatment. So it's often not clear-cut. It's often not treatment effects or tumor recurrence. It's often a mixture of both, which makes things even more complicated. Here are some examples of pseudoprogression after chemoradiation, for example. Here's pre-radiation scan. Here's 2 weeks post-radiation. Here's 10 weeks, 18 weeks post-radiation. You can see this lesion continuing to grow. As the patient didn't change therapy or anything and just was under careful observation, you can see that over time, then the tumor began to shrink. And this is what's characteristic of pseudoprogression or these treatment effects, is that there's this transient or temporary increase, but then it either stabilizes or kind of decreases over time in size. Here's an example of a recent study that we published looking at pseudoprogression after immunotherapy. Here's the pre-treatment planning scan here. So you can see the enhancing lesion here. They were given an infusion of a drug, which we labeled with gadolinium to kind of see where the drug covered. But then you can see by 30 days that tumor looks dramatically larger. But without any other interventions, over time, you can see this lesion starting to get smaller. First it stabilizes, then it shrinks. And even more than a year later, after this first-line therapy, after this therapy, you can see the tumor even smaller. So some things to keep in mind in trying to understand whether or not this is tumor recurrence or this is treatment effect is that recurrent tumor continues to grow over time. It doesn't stabilize, it doesn't shrink, it continues to grow, uncontrolled. Also, it often tends to occur at the same time as neurologic impairment. So if the tumor is getting bigger and the patient is feeling worse, that can be an indication that it's actually a growing tumor and something should be done about it. We can also use advanced imaging techniques to kind of give us some indication of if it's more treatment recurrence or pseudoprogression. One technique is looking at perfusion. So perfusion is looking at the intact blood vessels and not just dependent on the leakage of contrast out of the blood vessels. Here you see an example, again, of recurrent tumor. You see all of this contrast enhancement here. And you can see here, these are cerebral blood volume or CBV maps. You can see in all of those areas, they're high or bright, meaning that they have high blood volume, indicating that this is probably tumor. Recurrent tumor will also take up a lot of PET contrast, typically on amino acid PET. So you see this whole area here, all of it is, accumulating that biochemical, indicating that it's using that to grow more tumor. On MRS or MR spectroscopy, you might see a high choline peak indicating high cell turnover. And on pH-weighted MRI, you'll see areas of high acidity localized within the tumor, meaning that they have this abnormal metabolism that seems to be characteristic of tumor, of growing tumor. Alternatively, with respect to treatment effects or pseudoprogression, these tumors tend to have a transient or temporary increase in size, but they'll stabilize or shrink over time. So with careful observation, we can kind of tease this out typically just by close monitoring. Often patients are neurologically stable or not having increasing deficits, so it's okay to kind of watch this over time. You might see shrinking or no apparent perfusion abnormality. So you see in this case, this patient has a new contrast enhancing lesion here, doesn't seem to have elevated blood volume in that area, indicating that this might be just treatment effects and damage to those blood vessels. It might have low PET uptake. Here you see a patient where we're worried that this was tumor progression. This is a lower grade glioma, but we thought it was expansile. And you can see here that very little accumulation of that tracer. Again, there's probably some residual tumor here that's taking up some PET, but doesn't seem to be growing avidly. You might see low choline peak on MR spectroscopy, and you might see low acidity on the pH-weighted MRI. So here you see patient with a new enhancing lesion here, and relative to this previous tumor, you can see that there's relatively low acidity within that environment, indicating that this might be just damage to those blood vessels and not necessarily aggressive tumor. So with that, I'd like to thank you for your attention. Happy to answer any questions.
Ben, thank you so much for such a great overview and presentation. Really outstanding. I'll hand it back to Rachael for wrapping things up and talking about the overview in a few minutes. But first, I wanted to give a quick example how the National Brain Tumor Society collaborates with innovators like Dr. Ellingson in the field of brain tumor imaging. National Brain Tumor Society has a dynamic research roundtable program that brings together all the stakeholders in tackling tough barriers that really need to be overcome to advance new treatment and drugs for brain tumor patients. These stakeholders include treating neuro-oncologists and neurosurgeons, leading researchers like Dr. Ellingson, biopharmas, patients, patient advocates, and really importantly, regulators from the FDA. One of the recent research roundtables was in close collaboration with Dr. Ellingson and other leaders in brain tumor imaging that explored what should be the process and evidence requirements for developing a new brain tumor endpoint with a focus on imaging. This meeting led to a formation of a small working group to establish recommendations for a new clinical imaging endpoint for brain tumor trials, with the overall goal of better capturing and documenting, whether a drug is working or not. It's similar to what Dr. Ellingson was talking about in the presentation about the rates of change and looking at the flip books and seeing if the tumor is actually the treatment is having an effect. This continues to be a really important work in progress for NBTS in this working group, and we look forward to reporting back to you in the near future. With that, I'll turn it back to Rachael.
Kirk, thank you so much. One just very brief topic I wanted to touch on before we begin to close out is a very common and real experience of the brain tumor community, and that's scanxiety. Many in the brain tumor feel that every time they are preparing for their next scan. And we wanted to quickly recognize for you that you are not alone in that experience. And when you are having that, we encourage you to talk to someone about how you are feeling. In our National Brain Tumor Society Brain Tumor Support Conversations, scanxiety is a very common topic that we talk about almost every month. We meet the third Sunday of every month at 7 p.m. Eastern Time. And if you want to connect with the community and perhaps talk about those experiences, we encourage you to go to braintumor.org and register for our next session. I would also mention to you that sometimes when you are dealing with scanxiety, taking care of your mental well-being is an important way for you to try and deal with those very real feelings. And National Brain Tumor Society has our Meditation Mondays, and it gives our patients and caregivers an opportunity to practice mindfulness and meditation and find a little peace of mind when you are dealing with those really difficult feelings and that anxiety. With that said, I want to take a moment to thank you, Dr. Ellingson, for providing truly what was an outstanding presentation for our community. You went above and beyond in answering their questions and also helping them to better understand the advances being made to improve brain tumor imaging that will hopefully provide patients with better outcomes. And Kirk, as always, thank you so much for helping us and being with us today as we break down these concepts for our audience.
No, absolutely. And, maybe I'll just take a minute as well, because in now reflecting on the presentation and thinking what the key takeaways are from, looking at all these imaging techniques, whether it's a CT scan or MRI, all the different flavors of MRI, PET scans, I think that for me, what it comes down to is that you really see you're assembling a toolbox of technology that can be utilized. And it's not, one thing one thing fits all. It's really about depending upon what your specific, tumor is, and how the course in your treatment, you can utilize all of these. And it's really important to talk to your neuro-oncologist, to your neurosurgeon, to your radiologist, to really figure out, how to best incorporate all of these into your treatment plan. And don't be shy, really get in there, and, you're not going to go into the detail that Dr. Ellingson went into, but you want to understand really, why things are being done, and are you is the technology that's being utilized at your center really good technology? And don't be afraid to get a second opinion. So we could talk for a long time on this, but I'm just, again, thank you, Dr. Ellingson, for the really fantastic overview, and look forward to maybe a return visit somewhere down the road.
Happy to. Thank you so much. I appreciate it.
With that, I also want to thank you, our community, for joining us to be informed about innovations in brain tumor imaging and what that means for patients and caregivers. Please join us in November for our next installment of Informed in 30 Immunotherapy with Dr. Dwayne Mitchell, Director of the Clinical and Translational Science Institute at the University of Florida and co-director of the Wells Brain Tumor Center at the University of Florida Health. Thank you so much for joining us.